So good evening everyone. Today we will be discussing about the Osh Mahotsav Scholarship Test 3. Subject was Pharmacology. Total 20 questions were there. Okay. So we will be discussing one by one each question. So first question was, when two different chemicals act on two different receptors, their responses are opposite to each other on the same cell, what this phenomena is called. Okay na, so before going into the question detail, so what is chemical antagonism? Okay na, chemical antagonism means direct chemical interaction between the two drug. Okay na, so direct chemical interaction between the two drugs. Okay na, they can lead to either inactivation of one or both. For example, chelating agents. Okay na, so chelating agents are the example of chemical antagonism. Next is competitive antagonism. Competitive antagonism means antagonist competes with an agonist. Okay na, so here antagonist is competing with the agonist for the same binding site. Okay na, so for the same binding site in the receptor, they are competing with each other. So these are competitive antagonists. Reversible antagonist means whenever we are having any antagonist which is binding to the receptor, okay na, and if we will increase the concentration of agonist and which lead to the displacement of antagonist, which displaces antagonist, okay na, that is called reversible antagonism. Means right now my receptor is blocked. If I will increase the concentration, that antagonist will displace from the receptor and now agonist can bind. That is reversible antagonism. Next is physiological antagonism. Physiological antagonism means we have two drugs, okay na, which act on different receptor to produce opposite effect. Okay na, so to produce opposite effect, these are called as physiological antagonism. Okay na, and they are producing the opposite effect with same system or same cell. So for example, here the example will be adrenaline and histamine. So if you know, adrenaline is causing vasoconstriction and histamine is causing vasodilation. Okay na, so these are our physiological antagonism. So here you can check, the question is asking they are binding onto the two different receptors and responses are opposite to each other. That is our physiological antagonism. So here correct answer will be physiological antagonism. Next question is asking which is the correct statement regarding the graph. So this graph, if you know, it is showing us dose response. So if you know, we have drugs which can be agonist, which can be partial agonist, which can be inverse agonist, and drugs which can be antagonist. Okay na, so we have these four types of drugs mainly. So why we are having, suppose I am taking a baseline, so this is my baseline, this green one is my baseline. Okay na, baseline means this is my baseline. Okay, so second question is related to which of the following statement correct regarding the given graph. So this is the dose response curve. In dose response curve we have drug which can be agonist, which can be partial agonist, which can be inverse agonist, and drugs can be antagonist. So these are based on their intrinsic activity. Okay na. So we have baseline. Baseline means normal function of the cell. So if any drug is binding to the receptor and it is producing intrinsic activity maximum, means +1. So this is our agonist, means they will stimulate or they will produce the maximum function. So agonist will produce +1 activity. Partial agonist means they will produce sub-maximal effect. So their effect or intrinsic activity between 0 to 1. Inverse agonist means they will make the action opposite to the antagonist. So they will be opposite to agonist. They will be opposite to agonist. So they will produce -1 activity. And we have drug which can be antagonist. Whenever any antagonist will bind to any receptor, they don't have any action. So no action of itself, means they will not produce any action, but they can interfere with other drugs. Okay na? So they can interfere with other drugs. So their intrinsic activity will be 0. So now we have to make it onto the graph. So this green one is my baseline. So C will be my baseline. Okay na. Now I need to check which is producing positive effect, which is producing negative effect. So if you can see this blue one, maximum effect, means this can be my agonist. Okay na. Then just below that we have blue one, or this B graph or B drug. It is producing effect, but it is not more than agonist. So it can be partial agonist. Okay na. Then we have drugs which can reverse the or produce opposite action against the against the agonist. So these will be my inverse agonist. Okay na. And this C drug, if you know it cannot change anything, these will be my antagonist. So this will be the graph. Okay na. Now I need to check which option is correct. So first option is saying drug B is partial agonist, drug A is antagonist. So drug B is partial agonist, correct. Okay na. This statement is correct. Drug A is antagonist, no, this will be incorrect. So this is not the correct option. Second, drug A is agonist, yes. Drug C is inverse agonist, no, because drug C is antagonist. Next option is saying drug D is antagonist, no, because it is an inverse agonist. Drug A is agonist, yes. D option is saying drug C is antagonist, yes. Drug D is inverse agonist, yes. So this will be the correct answer. So correct answer will be drug C will be antagonist and drug D will be, or drug D is an inverse agonist. So this is how we will solve this graph. So this is dose response graph. Next question is from ANS, autonomic nervous system. So in this question they are asking, an experiment on dog blood pressure was done by adding different drug. The drug added and effect are shown in the given graph. Experiment is done, demonstrate the, means what this experiment has demonstrated. So here you can see this was the graph. So you can see they are giving 2 microgram of acetylcholine. So whenever we are giving 2 microgram of acetylcholine, means it is a low dose acetylcholine. So whenever we are giving low dose acetylcholine, it will stimulate muscarinic receptor, and whenever our muscarinic receptor will stimulate, okay na, M2 M3, they will decreases the blood pressure. Okay na. So here you can see the blood pressure is decreasing, but it is for transient time. Next, they have increased dose to 50 microgram. So this is medium dosing. Okay na, we have given medium dose, and now here you can see there will be dose dependent intensification of muscarinic receptor. So here you can see blood pressure is coming down, and also it is taking time to go back. So it will decreases the blood pressure, but it is longer lasting compared to the low dose. Okay na. In low dose blood pressure is decreasing for the transient time. Okay. In third one, what they have done, they have first given atropine 2 milligram, then they have given acetylcholine. So if you know atropine, it is a competitive muscarinic receptor blocker. So it will go block all the muscarinic receptor. Okay na? So whenever we are blocking these, acetylcholine will not able to work. If acetylcholine will not able to work into the muscarinic receptor, there will be no change. Okay. But then they said after giving atropine, they have increased the acetylcholine dose to 5 milligram. Okay na? So if we will give very high dose of acetylcholine after giving or after blocking the muscarinic receptor, after giving atropine, which has already blocked the receptor, now here you can see there is sudden increase in blood pressure. Okay na? So they are asking what is the reason of this increase in blood pressure. So why it is happening? Because atropine has blocked all the muscarinic receptor. So now this large dose of acetylcholine is not able to work. So this acetylcholine will go and stimulate our nicotinic receptor. Okay na? NN receptor, where it will go and stimulate in autonomic ganglia. Okay na? Autonomic ganglia. Specifically if you want to know, it go and stimulate sympathetic postganglionic neuron. Okay na? And it will increases norepinephrine or epinephrine release. Plus it will also stimulate adrenal medulla, and when it will stimulate adrenal medulla, it will also start releasing more epinephrine and norepinephrine. And what they will cause? They will increase the they will cause severe vasoconstriction, they will increase the cardiac output, which will increase the blood pressure. So why this increase in blood pressure is coming even after giving acetylcholine? Because atropine has blocked all the muscarinic receptor, and if muscarinic receptors are blocked and if we are giving more and more acetylcholine, it will go and start working onto the nicotinic receptor. Okay na? So now we will read option. Antagonistic action of acetylcholine. No, this will not be the correct answer. Next is muscarinic action. If without atropine, it will be true, but with atropine, it cannot be true. Next is potentiation of acetylcholine. Potentiation of acetylcholine is not by atropine, because atropine is blocking the receptor, so it will decrease the acetylcholine. If I want to increase the or I want to do potentiation of acetylcholine, then I will add physostigmine, which is a acetylcholine esterase inhibitor, which will increase the acetylcholine. More acetylcholine means more parasympathetic nervous system, then there will be more decrease in blood pressure and decrease in heart rate. So this will not given in the graph, so this is not the answer. So correct answer will be nicotinic action, because by working onto the nicotinic receptors, they are increasing the blood pressure. Okay, so that's why whenever we are giving atropine before the acetylcholine, it will block the muscarinic receptor, and now this acetylcholine can easily go and work onto the nicotinic receptor. So correct answer will be nicotinic action of acetylcholine. Next is a hypertensive patient is having grade 4 renal failure and GFR less than 30 ml per minute. The physician wants to prescribe thiazide diuretic, which is the best drug. So if you know, generally thiazide, whenever you are using in chronic duration or in patient with renal failure, they will decreases the GFR. Okay na? Why? Because whenever we are using them, they are decreasing the GFR by their action, like they are decreasing the GFR. So whatever they are whatever is filtered from the glomerulus, it is absorbed in the PCT. So that's why if you know, thiazide can also work as antidiuretic. But here they are saying GFR is less than 30 ml per minute, then what drug you will give? So if you know, these thiazide need GFR or they need filtration, because they have only two mechanisms to reach to the site of action. One is filtration, other is secretion. So if filtration is very less, then they cannot reach to the site. So in this condition, we cannot prescribe him hydrochlorothiazide. we cannot give them chlorthalidone. Even same with the indapamide. So in this condition, if any patient who is having severe renal failure, GFR less than 30 ml per minute, then the best drug, or even you can say only thiazide you can prescribe, is metolazone. Even in the book they have specifically mentioned that if somebody who is having very low GFR less than 30 ml per minute, then best thiazide to give is metolazone. So correct answer is metolazone. Next is a patient was taking theophylline for bronchial asthma. After starting another drug, symptoms of theophylline toxicity started appearing. Which is the likely drug started? So if you know, we have two types of drugs which can be either enzyme inhibitor or enzyme inducer. Okay na? Why we need to remember? Because theophylline is a drug which is metabolized by cytochrome P enzymes. So if any drug which can inhibit cytochrome P, that will lead to the toxicity. Okay na? And if any drug which is an enzyme inducer, means it will decreases the efficacy of drug which are metabolized by the cytochrome P enzymes. So what are the drugs which are inhibitor? First you need to remember these, because sometimes they will ask you in combination. So valproate, ketoconazole, cimetidine, omeprazole, ciprofloxacin, erythromycin, isoniazid, and acute smoking. Okay na? Acute smoking and acute alcohol. Okay na? They are also our enzyme inhibitor. What are enzyme inducer? Means they will increase the activity of cytochrome enzyme. These will be griseofulvin, which is an antifungal drug, phenobarbital, phenytoin, rifampicin, nevirapine, and chronic smoking and alcohol. These will be the enzyme inducer. So now we have added some drug which has caused the toxicity, means we have added some drug which is a cytochrome P inhibitor. So do a phenytoin a cytochrome P inhibitor? No. Rifampicin? No. Griseofulvin? No. So all these three are enzyme inducer. Only inhibitor in this on the option is erythromycin. So if we will add erythromycin with theophylline, we will have theophylline toxicity symptoms. Even nowadays more questions are on to this, like P-glycoprotein inhibitors can cause digoxin toxicity. So if you will give somebody who is taking digoxin, you will add erythromycin or clarithromycin, it will lead to the digoxin toxicity. Or you are adding rifampicin with digoxin, it will lead to the decreased effect of digoxin. So these drug interaction, you can say they are asking more nowadays. So you need to remember at least this list of enzyme inhibitor and inducer. If they will combine any drug with these, you can understand, okay, which they are leading to the toxicity or they are decreasing the efficacy of the drug. Okay, so here correct answer is erythromycin. Next is, which of the following drug improves bioavailability and prolongs the duration of action of secunavir? Okay na? So if you know, in protease inhibitor we have one drug, ritonavir. Okay na? If you know this, ritonavir earlier made as an antiviral drug, but they found out it is a most potent enzyme inhibitor. It can inhibit cytochrome enzymes. Okay na? So by inhibiting this enzyme, they found out that it is used as a booster now. Okay na? So it will increases all other protease inhibitors function. So that's why it is nowadays used as a booster. So here correct answer will be ritonavir. Remdesivir, no, it cannot increase. No. Nevirapine, oh, it is in, I think like typing mistake, it is nevirapine. Okay na? And vitamin C can also not cause. So here correct answer will be ritonavir. So ritonavir is a most potent enzyme inhibitor That's why it is used as a booster with other types of protease inhibitors. So it will increases their activities. Next is 52-year-old female present with HER2 positive breast cancer that has become resistant to trastuzumab treatment. Oncologist is considering next line therapy. What option will be the most appropriate choice? So if you want to know breast cancer treatment is based on it is ER positive, means estrogen receptor positive, it is HER2 positive, or it is BRCA positive. Okay na? If it is ER positive, then the treatment depend on to the, like, female is premenopausal or she is postmenopausal. Okay na? If female is premenopausal, we will be using tamoxifen. If she is postmenopausal, then we are using letrozole. Okay na? So this will be the ER positive. But if in both the cases female is having relapses, then we will be using palbociclib. Okay na? This is a CDK4 and 6 inhibitor, cyclin dependent kinase 4 and 6 inhibitor. Next is HER2 positive. Whenever any breast cancer HER2 positive, drug of choice will be trastuzumab. Okay na? But any type of resistance develop, then we can use pertuzumab, lapatinib, and other NERA and all those tinib. Okay na? If it is BRCA positive, then we are using olaparib, which is a PARP inhibitor. Okay na? So here female is having HER2 positivity. So first option is bemuratanib. If you know, bemuratanib is a BRAF V600E inhibitor. Okay na? If it is a BRAF V600E inhibitor, it can only used in cancers which are because of this. So it is used mostly in cases of metastatic melanomas. Okay na? Next option is erlotinib. Erlotinib is a selective EGFR tyrosine kinase inhibitor. Okay na? So it is used in all those cancer which are because of EGFR mutation. So EGFR mutated non small cell lung carcinoma and pancreatic carcinomas it is used. Okay. Next is soratanib. Soratanib is a multi-kinase inhibitor. Okay na? It can inhibit multiple kinases like RAF kinase. It can inhibit VEGFR, vascular endothelial growth factor 2 or 3, and it can inhibit PDGFR beta, platelet derived growth factor beta. So that's why it is approved in cases like hepatocellular carcinoma, renal cell carcinoma, and some thyroid carcinoma. Okay na? So here correct answer will be lapatinib. Lapatinib is a oral dual tyrosine kinase inhibitor. It will inhibit EGFR and it will also inhibit HER2. Okay na? That's why anyone who is having trastuzumab resistant HER2 positive breast cancer, lapatinib will be the drug you will prescribe. So here are all the tyrosine kinase inhibitor, BRAF inhibitor I have explained. Next is a patient with malignancy is undergoing chemotherapy. Platelet count were reduced after previous cycle of chemotherapy. What drug can be used to treat the patient? Means they are saying after chemotherapy patient has started developing thrombocytopenia. So what drug you will give to treat the thrombocytopenia? thrombocytopenia. So the correct answer is April-vaccine. Okay now. So why April-vaccine? It is a recombinant interleukin 11. Okay now. Whenever we are giving this, it will go and stimulate proliferation and maturation of megakaryocytes. It will treat thrombocytopenia. Why not filgrastim? Because filgrastim is a GCSF stimulator, means granulocyte colony stimulating factor. So it will go stimulate them. So it is mostly used in cases of neutropenia developed after the chemotherapy. Why not amifostine? Amifostine is a free radical scavenger. Okay, na? It will scavenge all the free radical, or it will remove all the free radical. So it is used to decrease the toxic effect associated with chemotherapy and radiotherapy. So simply I can say it will protect non-malignant cell from the radio or chemotherapy. Erythropoietin is mainly used to stimulate the RBC formation. So it is used in patients who are having anemia with chronic kidney disease or any anemia because of chemotherapy. Okay na. So in this condition they are asking us about the platelets. So answer will be April-vaccine, okay, which is a recombinant interleukin 11. Next question is, a 50-year-old male presented to ER with history of roadside accident. He was operated with spinal anesthesia. Post-op 1 day after the operation, patient has labored breathing, nausea, vomiting. Last stool passed 3 days ago. On his examination, he has distended abdomen, tympanic node, scattered bowel sound. Water-soluble enema failed to relieve the symptoms. X-ray of abdomen and CT is ordered. Which of the following drug is approved for this? Okay, na? So this is the classical presentation of colonic pseudo-obstruction. Okay, na? Colonic pseudo-obstruction, which is also called as Ogilvy's syndrome. Okay, na? So this is the presentation of this. So what are the symptoms? Significant abdominal distension, you will see post surgery, you will see nausea, vomiting, tympanic node on the post surgical. Okay, na? So in this condition, why it is happening? Because of decreased motility of GI tract. Okay, na? So decreased motility of GI tract. So what treatment you will give? You want to increase the motility. So treatment will be drug which is a acetylcholinesterase inhibitor, that is neostigmine. Whenever you will give neostigmine, it will increases the level of acetylcholine, which is a parasympathetic stimulation, which will increases the colonic motility. Neostigmine is a FDA approved drug for the colonic pseudo-obstruction or Ogilvy's syndrome, and you can administer it IV with continuous monitoring, because it can also lead to the decrease in heart rate and bronchospasm. So you will also monitor bradycardia and bronchoconstriction, and you can give continuous IV post surgery. Okay, now why not atropine? Because atropine is a muscarinic antagonist. It will block the receptor, so they are not able to work. Acetylcholine cannot work. Dantrolene, if you know, we are using it for malignant hyperthermia. Okay, na? Next is pralidoxim. Why not pralidoxim? Because pralidoxim is a acetylcholinesterase reactivator. Reactivator means it will increases the degradation of acetylcholine, so it will decreases the acetylcholine. Okay, so dantrolene we are using as it is a direct skeletal muscle relaxant used in hyperthermia and spasticity. Pralidoxim is a acetylcholinesterase reactivator, which will decreases the acetylcholine, and if you want to know, it is the antidote for OP poisoning, organophosphate poisoning, along with atropine. Okay, na? So this is the answer for this question. So neostigmine will be the answer, because motility is decreased. I will increase it by increasing the acetylcholine, so I can give acetylcholine esterase inhibitor. Next is a 32-year-old HIV woman admitted to the hospital with severe confusion and dizziness. She has been non-adherent with her HIV medication several months, developed meningitis with Cryptococcus pneumoniae. What is the most appropriate? So if you know, for Cryptococcus infection, drug of choice will be amphotericin B and plus flucytosine. Okay na? So this will be the drug of choice. Why we are combining them? Because if we are combining them, amphotericin B will increases the penetration of flucytosine, so which will help to treat the Cryptococcus neoformans. Why not anidulafungin? Because it is not having any role in Cryptococcus infection. If you know, is isavuconazole, it is for mucormycosis. Okay na? So it has no role in Cryptococcus neoformans. Why are not flucytosine alone? Because flucytosine is having very high chances of resistance. Okay na? That's why we are never using flucytosine alone. So the answer will be amphotericin B plus flucytosine. If you know, amphotericin B is having two part, hydrophilic, lipophilic, and they are forming micropore. They are uh, they are creating pore into the membrane of fungus, and then they are doing all these mechanism, and it is the highly toxic drug. It has nephrotoxicity or ototoxicity, bone marrow suppression. Okay na? So this is the answer for this condition. Next is, which of the following agent is the only FDA approved intracellular chelating agent specifically indicated for prevention of doxorubicin induced cardiomyopathy in pediatric adult patients receiving cumulative doses? Okay na? So here the correct answer is dexrazoxine. Okay na? Dexrazoxine. So before going into the dexrazoxine, we need to understand how this is causing, or what is the mechanism of action of doxorubicin. So doxorubicin is causing cardiotoxicity primarily by forming iron anthracycline complexes. Okay na? Iron anthracycline complexes, which generate reactive oxygen species, and they are inhibiting topoisomerase 2. Okay na? So they are inhibiting enzyme topoisomerase 2 in cardiomyocyte. Now how dexrazoxine is working? Dexrazoxine is a cyclic derivative of EDTA, and it can cross the cell membrane, and it hydrolyzes into the bidirectional chelating agent. It removes the iron from the anthracycline complex, and by removing this, it will prevent the formation of reactive oxygen species and also interfere with the topoisomerase 2 binding. So that's why this is the drug of choice for doxorubicin induced cardiomyopathy. Okay na? Typically it is reserved for the patient who already have received a cumulative doxorubicin dose of 300 milligram per meter square. Okay na? But like it is reserved for these patients who already have received these doses and require continuous treatment, because it can decreases the risk of congestive heart failure or cardiotoxicity. Next is why not amifostine? Just now we have discussed amifostine. Amifostine is a free radical scavenger, and it is mostly used with cisplatin associated nephrotoxicity. Okay na? So it will decreases the nephrotoxicity caused by cisplatin, or xerostomia caused by radiotherapy. Why not mesna? Mesna, if you know, it is a thiol compound used to prevent hemorrhagic cystitis caused by ifosfamide and high dose of cyclophosphamide, because it will neutralize acrolein. Why not leucovorin? Leucovorin means folinic acid. Okay na? So it is mainly used in the toxicity of methotrexate. Okay na? So methotrexate toxicity will be treated with leucovorin, and it can also enhance the effect of 5-fluorouracil. And there, so these are the antidotes or these are the drugs you are using to prevent the damage caused by anti-cancer drug. Okay, now so here correct answer will be dexazoxane.